Okay, hello everybody. Just making sure our slides are ready. We'll go ahead and start. Just give it a moment here. Okay. All right, well, thank you so much everybody for coming today. This webinar. This is being presented by NorCal Services for the Deaf and Hard of Hearing. This program is Deaf Plus Access to Advocacy. This project is supported by Department of Developmental Disabilities, DDS. So I want to introduce myself and the other presenter today who will be presenting on this topic. My name is Diane Olofsson. I work for NorCal Services for the Deaf and Hard of Hearing. I currently work in the Deaf Plus advocacy area. And now we'll go ahead and introduce Amanda. Hello, everybody. My name is Amanda Somdal. I am a licensed clinician social worker. I work with Alabama Department of Mental Health Services. I grew up in Southern California and lived there for many years. I actually just moved a few years ago over to Alabama. Diane says, thank you so much for being here with us. So today we will be discussing different topics. First, we'll have a video, and then I will be expanding on what Deaf Plus means. Then we will discuss communication needs, also deaf culture versus mental health culture, comparing the two. Also, culture consideration in the mental health fields and the perspective on that. Also, we will talk about language disfluency and what it means. And then at the end, we will finish off with the QA session. If you do have a question throughout the presentation, please do type that question in a chat or wait until the end for that QA session, then I can answer those questions. If you want to sign your question, you can simply raise your hand and then we will spotlight you so everybody can see you sign your question. If you would like to speak, wait until the ASL interpreter is spotlighted so that we can see your question being interpreted. Thank you. Okay. All right. So next slide, please. So we're going to go ahead and watch a video about mental health and different tips regarding that arena. Okay, we'll go ahead and start the video.
Greetings from NorCal Services for Deaf and Hard of Hearing. We work with Deaf Plus individuals as a way to promote equitable mental health services for Deaf Plus individuals. Deaf Plus means people who are deaf and have additional disabilities. Deaf Plus individuals are no different than the general population in experiencing mental illness. However, effective diagnosis and treatment requires being familiar with deaf culture, communicating effectively with Deaf Plus individuals, and understanding the psychosocial experience of being Deaf Plus. To professionals who are not familiar with deaf culture, a behavior that is normal in the deaf community may erroneously be seen as psychosis or another mental illness. Psychiatrists who do not know American Sign Language have a higher rate of diagnosing deaf patients with psychosis than psychiatrists who are familiar with it. The deaf community shares a common culture and a common language, American Sign Language, or ASL. ASL is a fully developed language away from English, with its own rules and structure. The language uses movement, space, and facial expressions, which convey tones, voice inflections, and emotions. It can be a challenge for mental health providers to distinguish language-based facial expressions from other nonverbal or non-linguistic behaviors. In our community, eye contact is vital to communication. A person looking away during a conversation in ASL is disrupting communication. For instance, a Deaf Plus person will wait until the professional and the ASL interpreter look at them before they start talking. Some physical touch in the deaf community is acceptable. For example, we tap someone on the shoulder to get their attention, and we hug with consent. Deaf-blind people rely on protactile, or tactile ASL, which requires touch to communicate. Deaf Plus people may approach people outside their circle or strangers, including their mental health providers, the same way they would approach their family and friends. Many deaf individuals experience language deprivation, which results from not having full access to a natural language during the critical period of language acquisition in the first 5 years of life. Deaf babies who are born to deaf parents using ASL have been shown to develop language naturally. But many deaf people are born to hearing families who do not understand that depriving them from sign language can lead to language disfluency. Some characteristics of language deprivation can be confused with symptoms of mental illness in the general population who are not deaf. For instance, they may confuse the past with the present, have difficulty grasping abstract concepts or feelings, and may exhibit poor emotional regulation or coping skills. It's important to always ask the Deaf Plus individual their preferred communication method. Writing back and forth and lip reading are never substitutes for communication in ASL. For effective communication, some Deaf Plus consumers may require deaf interpreters to be present in addition to ASL interpreters, because deaf interpreters possess native fluency in ASL and are able to facilitate effective communication. Interpreters with DBI certification may be required for deaf-blind individuals. Only use professional interpreters, not family members. Professional interpreters have undergone rigorous training and have professional codes of conduct rules to follow. Interpreters should be positioned next to the professional so the person can see both with ease. Even if a caregiver accompanies the Deaf Plus person to their appointment, the mental health provider should ask the Deaf Plus person directly if they want their caregiver to be present at the session and to communicate. If the caregiver is present, the mental health professional should communicate through the interpreter with the Deaf Plus person. Only if the Deaf Plus person cannot answer questions, and if permission is given, then the mental health professional can ask the caregiver to fill in the gaps. Understanding how a Deaf Plus individual communicates or uses language can help mental health providers to determine if language disfluency is present, and can help identify any support services in their treatment plan. Any treatment plan should consider the Deaf Plus person's ability to monitor their medication intake and to explain how they're responding to medication. The treatment plan may need to include an identified support person for the Deaf Plus individual. Follow-up appointments should evaluate the Deaf Plus person's response to medication in spite of any communication or language difficulties. And care should be given to identifying any side effects or the underlying reason that the person may have stopped taking their medication. In accordance with the California Lanterman Act, Deaf Plus adults have the right to refuse medication or treatment. Consult with deaf mental health professionals, deaf service providers in your area, or the deaf specialists at the regional centers. Use caution with evidence-based practices that have not been adapted to the cultural and linguistic needs of deaf and Deaf Plus individuals. Request interpreters who have experience and training in interpreting in mental health settings and interpreting for Deaf Plus individuals. Ask the Deaf Plus person for their preferred communication. Is it ASL, captioning, spoken language, a combination of any two, or all? For example, if they prefer sign language, ask if they have a preferred interpreter they use and understand. Having the same interpreter provides consistency. If the interpreter indicates that they are not understanding the Deaf Plus person, it's your responsibility as the service provider to request clarification. You may also ask the interpreter to describe the behaviors and language being used by the Deaf Plus person. It's a good idea to provide additional time for your appointments. Communication through interpreters can take more time. You can repeat back to the Deaf Plus person what they said through the interpreter to ensure the accuracy of information that was relayed. Deaf Plus people benefit from mental health services when given appropriate diagnosis and treatment that considers their individual, cultural, language, and communication needs.
Okay. Yes, so, okay, related with the video, we will show you the contact information at the end if you all didn't miss that. But we will expand and explain that a little bit more as far as each area that you all did watch on the video today. So we will go forth with that in another few minutes. Let's go to the next slide, please. So we discussed about Deaf Plus and what it actually means. Deaf Plus, and it's spelled deaf, DEAF, and then plus, PLUS. And there's three different areas within that. So that's people who are deaf and do have deaf or hard of hearing or deaf blind, but there's an added disability within that as far as like intellectual, if it's intellectual or either developmental disability, that is considered as being Deaf Plus. So having a deafness and an extra type of disability. So through California, we do have a law. Yes, and this law is called
The Lanterman Act.
Thank you. And that is for people here in California with the developmental disability like autism is considered as Deaf Plus, and it explains information related with that as far as developmental disability. It gives the details there. But it's a person who is labeled with a disability before the age of 18. And then they continue to have that labeling of disability for the rest of their life. And it's substantial. as far as you can see, it's DD as an acronym, but there are 5 different categories. It's intellectual disability, autism, epilepsy, cerebral palsy, or other conditions that are similar that related with treatment for intellectual disabilities. So under those 5, they must have a substantial disability, meaning they have limited functional abilities in 3 areas, at least 3 areas. So just thinking about making sure I can cover everything, but those 3 areas could be as far as self-care, maybe not being able to sufficiently do that, expressive or receptive language is limited with skills, and then the learning abilities, maybe mobility, maybe it's impossible to have independent living. So as far as like budgeting with money, being successful in that area is covered under those different categories that I was mentioning. So say under the 5 different categories, the first 3, so it has to be adequate under that description of that acronym of DD, but then this whole, as far as providing the services here with this project, is focused on deaf plus individuals. So those individuals who are labeled with having deaf plus being deafness and additional disability. And then it explains here on this slide as far as having added support related with those developmental disabilities. And we can go on to the next slide. Okay, and I'm gonna switch it over to Amanda, and she'll take over from now. Thank you so much. Thank you for that nice introduction. Okay, so I will go ahead and explain in depth about as far as communication needs with deaf plus individuals. I'm used to signing deaf and DA as meaning deaf and disability, but I will respect the new acronyms as far as deaf plus. But there are many people who have, a variety of different types of communication needs. For example, it could be one example of a communication need, to expand on that, it could be maybe receptively. It's different than expressive need. It's not necessarily the same. Maybe the processing when it comes to the mind and then the sign ability to express it, it may be awkward and needed more time or a different approach related with those signs and getting that expressed or receptive skills. So you have to be patient as far as when it comes to their answers and being able to negotiate back and forth with their communication. And not to mention also as far as with the signing, ASL, American Sign Language, gesturing, as far as just having just general gesture signs of just saying hungry, come here, thirsty. And sometimes with gesturing, maybe the caregiver knows more of what the individual is meaning, because before, the person who is considered as deaf plus, their caregiver, it was just simple gesturing, but they were able to have communication, but it was clear communication through the 2 of them. They developed their own language. And sometimes the caregiver has to provide more information related to those topics or that the individual may be speaking on because they're used to their language. There's also another acronym, PSC, and
PECS.
that is, what was that? I'm sorry?
PECS, PEC.
PEC, excuse me, that was the interpreter error. But as far as if you can look on the slide there's information related with that as far as with, it looks like kind of like a picture board. And that person will literally just point to what their needs are, or maybe you will point to provide communications between the 2 of them. Maybe it may be, yes, visual communication aid is what I was trying to mention, but that is what that picture board is called. Then there's the AAC, And that is related with the automated communication. There's pictures that are on there where you can literally, it's like you hold it and it's got like some type of flap on it. It's like a machine that you can kind of carry around. And sometimes you'll have to plug it in to have power. But it's a touch screen, and when you push it, it'll speak. So you'll be able to touch the different things that you may want from that. And of course, there's more expensive ones that have full language, but there's a general one where it will say, mentioning the person's need as far as flashing. It'll have the pictures on there, then they'll tap what they need, and then the pictures will comment the need at that point. There's pro-tactile, and that's where the deaf-blind to communicate through using their hands and touch. Here's an example of that as far as signing through a deaf person, and then there's a deaf person and there's a deaf-blind person. So they will sign, but the deaf-blind person will have their hands set on top of the person who's communicating, as I'm showing here, and they're able to understand communication through that touch, as I'm showing here. And it's a hand-over-hand communication is what the technical term is for that. And then there's also different promptings as far as touching. Those are different examples as far as someone letting them know cues related with their arm. Say maybe there's an X filling on their arm. So that means, emergency, will need to leave, so they'll know at that point. So that's just something that I've learned new within that. But there's different ways that Deaf Plus people can communicate. And that is important for, especially if someone comes into your office and they're trying to figure out what's the best way to communicate. This is important to provide clear access related with their communication need, if it needs to be an interpreter and equipment provided, or either a deaf CDI, a certified deaf interpreter, to provide that communication. Now, I am definitely very passionate and strong within the mental health community. There could sometimes be misunderstandings related with the deaf culture, and it just tends to be deaf culture way related to another culture, and pretty much bringing those cultures into the same realm. Sometimes they aren't successful. So the person who is considered as Deaf Plus may have a hard time with this type of professional environment. So the register, when it comes to their speaking, it may seem like it's rude, it wasn't acceptable, it's not polite, it's not formal, but those that know that is part of the culture. So like as far as deaf culture. So here's an example with that. Deaf culture, we usually like to touch a lot. So these are patting or touching, and that could be on the arms, hugging, placing your hand on someone. And that's more of our communication style, touch. There's more touch as far as getting someone's attention or showing some type of emotion, affection. And yes, we do a lot of hugging and, just high fives, a lot of praising, just expression of our emotions. Sometimes that can come through physical touch as far as hugging and giving high fives, laughing, excitement, just showing those emotions through touch. And that is how you make that relationship with people who's in the room. That's, and as far as giving their name and introducing each other, that's kind of how that happens with meeting and through touch and communication. So just, when we have that communication, we discuss, where are we from? Do you have any children? Just getting to know everyone as far as with your animals. Do you have any pets? Do you have any pictures? Where did you go to school? That's just pretty much the general of opening up about yourself, that general information, and just really learning about that person. It's very open with sharing. And so before, it had been like a wall type of standard, but now more of just sharing open happiness with getting to know each other. And at this point, we're going to switch interpreters.
So in the news, a lot of times things are portrayed differently, such as like wars or maybe active shooters, or maybe there is an award show, different types of things. These things like that are typically discussed within the deaf community culturally. Also, the exchange of personal information is also again, this is very surfaced information, but that is very common within the deaf community. Now, when it comes to the mental health arena, typically a lot of those things that I've discussed are not usually touched on, such as physical touch, hugging. Usually you are sat within a distance. You are not in close proximity with the other person you are serving or supporting. Also, clients have experienced a lot of trauma, so physical touch may trigger them. So you have to be very careful where you touch. Maybe it's not okay to touch them on their shoulder, but it's okay to touch them on the hand. Of course, you will know that with that client, but you just have to be very careful when it comes to touch. In the mental health field, also sometimes connections, therapists between client and adding an interpreter to the realm, that relationship of me, it's kind of like a triangle, so having me relate to the interpreter relate to the client, or even if you have a caregiver, it becomes a square. It's a four-way relationship. So when you build a connection with a client, typically you have strong boundaries and you are limited on those interactions. But the connection between the caregiver, interpreter, and the counselor may be a little bit more flexible, because you would have to exchange information to provide better care for that consumer. It really just depends. But really just being more knowledgeable about the exchange of information. Really, information usually is more one way in the mental health arena. Typically, the therapist receives all of the information from the client, family history, school history, but the therapist does not expand on their personal experience, maybe where they graduated from college, and if it's an appropriate setting, they may talk about their family, maybe at a superficial level. You'll be able to share things such as your favorite color, or maybe why that information is important. Again, very, very limited situations on information exchanges, and the therapist usually does not expand on it. Usually the environment is in a controlled environment by the therapist. Typically, we don't jump around topics. Therapist chooses the topic, or maybe the client chooses the topic. But again, this is within a time limit and only sticking to one. Again, thinking about mental health culture and deaf culture, they clash. There's a lot of misunderstandings, and there's a lot of misinterpretations, and there are a lot of imparallels. When you work with a deaf plus individual, it's really important and vital to keep in mind that the behavior that they're expressing may be appropriate in deaf culture, and maybe it is not a mental health issue. So it's really important to become aware of that during your assessment of deaf plus individuals. Next slide, please. So I really want to take a little bit of time to focus on mental status examination. This is very common within the mental health field, and sometimes a little prominent in the medical field, but mostly mental health. This can happen every session during your assessment of the consumer, typically a little bit more during the intake session. It's a little bit more of an assessment. I have only picked and choose a few to expand on because these are the most common you see and typically most common misinterpretations by hearing therapists in general. They will assess a deaf person, deaf, blind, deaf plus, and so on. They will make errors during that assessment. So I want to expand on these things. For example, one portion of mental status examination, I'm just going to create an acronym for it, MSE, is speech and language. This is a very common mistake that hearing therapists make. They will put down, oh, this person is mute. They don't talk. Well, let's analyze that a little bit. Speech for MSE does not talk about being able to speak and vocalize. It talks about the content overall of their expression. If they're a deaf, deaf plus, deaf blind, deaf disabled individual, how can they express themselves in their native language? A deaf plus person pointing to something and they may use an alternative mode of communication that can also be assessed as their way of expressing themselves. Or is this deaf plus individual or caregiver, is this their norm? Is this something that they're comfortable with? And maybe if you're asking them questions and it's taking them a while, is this different? Or maybe if they just take a while in general and it takes a little bit for them to respond. That's pretty common for MSE that I see. My notes are pushed to the side here. Just give me 1 minute to pull them up. So when you look at quantity of signed speech, the pressured speech really boils down to how the person shares their ideas and how they share their thoughts. So do they have to say things right away? That means you can't interrupt that process. Right? So, or maybe say, hey, hold on, and they want to keep talking. Or maybe they jump from topic to topic, and there is a multitude of different things that they're saying within their statement. One culture consideration you need to think about is oftentimes, and really this is very often, deaf people have the ability to have a conversation, right? I mean, not often, right? You know, within big cities with a lot of deaf folks, oh, there may be plenty of access to communication, or maybe if you go to a deaf school, there may be plenty of access there as well. But a lot of deaf people are usually isolated, especially the deaf plus population or deaf blind. They don't necessarily have access to communication all the time, and they don't have people visiting to talk to them, which means they hold on to information for a very long time because they don't have anybody to talk to. So finally, maybe when they're around a lot of people, but someone may not be there to talk with them, you know, they may hold in information, and maybe the people don't understand me as a deaf plus person. So typically I'm quiet until somebody approaches me who does know ASL. There I talk about everything that I've been feeling for months because they're so excited to talk. It doesn't mean that they're pressured speech. It's not that. It's because they've held in information for so long and they didn't have access to actually chat with someone who understood them. So really, we have to make an assessment of pressured speech. Is it a mental health, mania, psychosis, or is it an opportunity to communicate with someone who actually understands them for the first time in a long time? Oh, I have so many stories I can share with y'all, but I'll move on. So now looking at poverty of speech. This is when a person has limited signing speech and you have to constantly remind them, hey, and prompt them. Again, going back to culture considerations, is the delay in processing due to the interpreter, because this is a three-way consecutive conversation? Or maybe you have a Spanish interpreter, also an ASL interpreter, plus a deaf interpreter and a caregiver, and then you have the consumer. That is a five-way conversation that takes a extreme delay. And if there is any misunderstanding between the five people, then we have to go back to the beginning, make that clarification, and go through that five people again. So is the delay due to the client or is it due to the interpreting process? Also, is the delay due to their processing time? Maybe they look at something and maybe looking at words or maybe lip reading, maybe it'll take a little bit of time for them to understand. When deaf people lip read, they have to really focus in on the lip area and the expressions you are making and really think about the environment and the placement of words. There is zero time in these types of settings in order to do so. Like, oh, you said, oh, you want to go to the baseball game tomorrow night. Can I go? Oh, you want to go to the baseball game tomorrow night? Oh, okay, cool. Hold on, let me think. And now let me try to answer that question after I try to figure it out. So I have to lip read first, and then I can think about my response. That's not a delay in response. That's just due to me being able to understand your lips. Another culture consideration is a lot of deaf folks, especially the deaf plus population, are taught that they're not important. Sit down, be quiet. Your responses are invalid. I'm going to do it for you. So as a deaf plus individual, usually they feel insufficient. They feel that they are not important. And oftentimes they're not used to being asked questions regarding their feelings or thoughts. So maybe it will take time for them to think about it. So now quality, when it comes to volume, what this means for hearing people is sound. So if somebody is speaking very loudly, or maybe they're speaking in a very small tone, now looking at a deaf plus person, they may sign very big or they may sign very small. You know, they have different sizes where they sign. So there is sometimes an ASL interpreter, and there also is a deaf interpreter at the same time. And they support with cultural information as well. Whilst the deaf plus individual is signing, that either is typical for the deaf community or atypical for the deaf community. And we will rely on our interpreters to really incorporate different things that may not be typical. Maybe they sign very small. Maybe that may be due to their vision, or maybe that's just how they learn language. And I am simply copying the hearing person who taught me language, and I copy the way they signed. So really, you have to become a little bit of a detective and really find out where they learned language from, and that'll really help your assessment. The interpreters are going to switch.
Yes, and that shows the variance within the signs as far as the emotions being high, and then maybe they're a little bit lower. So it can kind of shows the variety within the sadness and the happiness within the language, and the fluidness within the signs, being comfortable with the signing, the concepts, the language, the grammar structure. Are those things all incorporated? So that's something to think about. So yes, on this next point, when it comes to spontaneity, trying to figure out as far as when they're interrupting, maybe the person is misunderstood and they're excited about their communication and they have an interpreter there, and the interpreter is able to understand me, and it's a real person, like live, and we're able to have a lot of communication. We're able to share between communication with each other. So that's really exciting. So definitely have to learn those boundaries as far as formally, and then what it looks like as far as the back and forth turn taking. The communication style is also something to think about. Is that a normal tendency, or is it a little bit miscued? So those are something to think about. The last point on this is related with orientation. And this is a bit of a sticky topic, sarcastic. So often hearing people hear language intentional hearing, as far as what you're listening to the radio and driving, and you're maybe thinking about something, but something that we learned this month, and now it's raining. Tomorrow you're thinking about that and the weather, and then you arrive to work and you hear just some comments that are happening from some of the employees are not happy with as far as the boss, so they're making some comments about that. Then you go over to the elevator and you hear some elevator music, and you go on around the corner into your office, and you're able to pick up information as you're going in to your specific location. But deaf people, they have to rely on their eyes, direct communication. So as far as themselves being able to see the advertisement on the news, commercials, TikTok, social media, friends giving their information, or even saying, oh, did you know there's a certain something going on? Or maybe there's an app, the weather app, the news app, to be able to read and research those different things, and maybe even discuss those with their friends. And then they maybe make a comment saying, oh, did you hear what happened this morning? And they'll kind of go on with the conversation at that point. And that's how that information is gathered. So related with the as far as information, as far as someone telling them to come on, let's go on for a ride, or they're saying, don't say anything. We're good. Don't say that you're going to go. Maybe they're saying we're going to go and meet up at a specific critical location, and that's where the social worker is at. But they don't necessarily say all the information. They just say, come on, come with me. And the person just joins on with the ride, gets in the car and goes on, kind of looks at scenery as they arrive to the location, and they may get to the building, they go in and they just continue to just look around, don't really know what's going on. Then they see the front, and the person saying, come on, sign your name. And I put your name there. And then the person literally puts their name on there, and they go and sit. And they think when they get there, they're sitting there like, why am I here? And they're saying, come on, let's go. They pat them and say, come on, follow me. Then they go into the room, and the person is still sitting there, like, what's going on? And then someone comes in the room and says, hi, how are you? And the other individual's like, I'm fine. Then it's asked as far as, is there an interpreter available? Then the caregiver They'll inform the caregiver as far as when it comes to different questions and asking names and whatnot. And the individual will say, I don't know what's going on, So it's misinformation. That's the point of it. Sometimes I myself will, let me give this example. So we'll go and maybe there's an interpreter there in the room and they'll say, well, who is this person in the room? And the caregiver will say, well, this is how they're going to explain what's going on. They're going to use a sign language interpreter to explain what's going on in the room. Or maybe they'll point at their parents and their family and or their caregiver and they'll point and they'll say, well, who is that? And then the person will have to explain and say, oh, that's my mom. As far as like finding out supplemental information. So it's possible as far as knowing who that is and explaining that background information. And then they'll say, oh, okay, well, that person knows what's going on and they'll take over the situation at that point. But the situation is saying that we have to be able to inform what's going on as far as what's in the building. You have to say the name of the specific building. It's the care center, but then that information is not known or even said. So then they'll say, what is this? What is this place? And instead of saying this city, they'll give the information, they'll say the name. They'll just say the city location, but they don't necessarily give the details as far as why we were in this building or at this specific city. So then going on to time, as far as looking at a digital clock, many do not know analog. As far as with the hand, the different time hands on there with the time ticking. But anyways, they don't know those. So it has to be a digital clock to be able to see and understand what time it is. So that is something to incorporate. And then sometimes in the mornings, it'll be maybe 11 o'clock. And the person will say, is it 11 o'clock? And they'll look at the watch and say, yeah, it's 11 o'clock. And that's how they get that confirmed information as far as the time. Now, again, anyone can let them know that the information that's going on here, but often deaf plus, deaf blind, and deaf people are literally just taken and placed into a situation without any type of background information. So when they get there, they're like, hi, what are you doing here? And they're like, I don't know. They'll point to this person and say, they brought me here, and then they'll say, I don't know, and ask them. So we have to really be careful when it comes to evaluating them. Why don't they necessarily know that specific information? Is it lack of access? There's no one literally providing the information to them? Or is it a disconnection? Hallucination? Just not being aware of which is the, I won't say issue, but just where the help is needed. So that is where that evaluation method is crucial. Okay, and now we're going to move on. We're going to keep on going with it. Can we go to the next slide, please? I'm going to touch a little bit on this topic related with language disfluency. And let me read over my notes just a second. It seems to be a newer topic, but it's really not. It's just becoming more popular at this point. This word has been around for
since Socrates.
Thank you. Since Socrates. So literally having exposure to this term is what causes language disfluency. And I will explain this. I want to let you all know, if you all will spell this word disfluency with an I, not DY, DIS fluency. That means a person who is hearing and their speaking is stuttered or just not clear. So maybe here's an example. They may comment about something and they're just like, oh, what am I trying to say? Oh, that's what I'm trying to say. So that stuttering part, that is the DIS, disfluency. And then, so here, there's 4 causes when it comes to this. There is the neurological problem. So it could be related with alcoholism within babies' infancy, and the rubella, rubella syndrome. There could also be as far as mental health illness. Amphilis, I'm sorry if I pronounced that wrong, but that's really just related with a brain injury and speaking. And then there's the related with tumors and things like that within the brain that could cause that. And then this last one that we'll speak on is the language deprivation syndrome. Now, this last one, the language deprivation syndrome, that is related with socialization with language. That's where it begins. So we cause that as humans. So it's not necessarily related within the body, it's related with social context. So not having access to language, not being exposed to language, but the language, as far as ASL or either speaking English, Spanish, whatever that language may be, it's just the point of it being any language, spoken language, even drawing, gesturing, art, just language in general. The point is just language access and exposure was not available to that individual. And it could be related with age and adequacy at that point. And now we're going to go to the next slide. I'm going to speak more in depth about language deprivation, this 4th topic here. It's, I'd say, around, I don't have a specific site, but it's about 65% of deaf individuals will experience language deprivation. And that seems like a high number, right? Wow. But deaf people, 90% of deaf people are born to hearing family members. And so then, the hearing family members will speak, but, not necessarily sign as much. So then they have to figure out as far as the emotions related with that. And it causes the child to be delayed. So they learn language from afar. So then when it's time to, finally realize, oh, I have to teach my child language, they're already behind at that point. So language acquisition, it can vary within the first 5 years of life. That is incorporated. The early intervention stage is the first 5 years of life. But as far as continuing to learn, it does happen after the first 5 years, but the structure is developed within the primary part, within the first 5 years, primary part of the brain. And then at that point, if there's no language exposure, then the brain will start to eliminate, die out, and not necessarily grow. So yes, it does not necessarily grow within the language. So that's what causes that delay and deprivation. And now we're going to switch interpreters.
This really impacts the brain. For example, language typically is in the frontal cortex of the brain. And most folks with LDS, language deprivation syndrome, their language is stored in the back of the brain, which is the optical lobe. And really, it's registered as pictures instead of language and words. So there's a huge difference there on how they really process information. And that has a crucial impact on deaf folks and how they actually understand language. There's just a lot of layers to this. So if they don't have language, this can impact deaf people in a multitude of ways: cognitive development, social skill development, theory of mind. An example of this is, suppose I bring out a ball and I have it in my hand, and you saw me put it into a basket. And you went over and looked into the basket and saw that the ball was gone. You, if you have theory of mind, you will try to actually create an analysis of why it's gone. Maybe it's in the basket beside it and see it's in there. But if somebody who didn't have theory of mind, if they saw that that ball was gone, they wouldn't understand why it was gone. They wouldn't automatically problem solve and look at the basket beside it. That's just an example of theory of mind. Also, delays in academic learning and achievement. This is crucial as well. Also, limited health literacy. Deaf Plus folks struggle with the understanding of simple things such as I need to eat less, or maybe they're a diabetic and they have to decrease carbs. They may think, well, I need to eat cookies. I want sugar. I like sugar. And when you tell them, hey, you're diabetic, you can't have that, they're not necessarily refusing your advice. They just don't have those neural pathways to make those connections. They don't understand that. So we have to constantly reteach so that they do make those understandings and connections. Also, higher chances for trauma, lower quality of life. You know, if somebody were to come to your office and you have already explained how to problem solve, and maybe they come back with the same problem over and over again, this means this person is suffering from language deprivation syndrome. Eventually, they will make sense of it. But again, it is a very slow process. It takes time and patience. Next slide, please. So really, in a nutshell, language deprivation is when a person is not a skilled user of their own native language. Can you imagine all of you who are present today, all of the participants, say you are supposed to be experts in English, French, and Japanese. That's your home language. You were born and raised to learn that language. And maybe you learned a second or third language, but your home language, which means this is the language your primary family speaks, and you're not fluent in that primary language because you were not taught or given access to that language. Think about what that feels like. It is so vital for us to understand language deprivation. And language deprivation is 100% preventable, and that's the sad part. This is preventable. And it's preventable by giving kids access to language. Next slide, please. Okay, so I want to wrap up on the different topics I've talked about. I know we kind of presented on a lot of information here. So the definition of deaf plus, this is a deaf person with an intellectual or developmental disability. And that's what defines a deaf plus person. People who are deaf plus have a variety of communication needs. And it's really crucial that you ask that deaf plus individual, what is your preference when it comes to communicating with me? Making sure that you hire a professional interpreter to interpret your sessions or meetings. Do not rely on the caregiver at hand, family, or friends. Professional interpreter is a neutral body, and they have extensive training on how to interpret information. Also, making sure that you talk directly to the Deaf Plus person. They are human. You want to build that connection. If they are unable to understand you, they may reach out to their caregiver, family member, or interpreter. And also make sure that you include them. Hey, do you want to meet weekly? How much help do you need necessarily? Or they ask their caregiver after you ask them. So make sure that you always put them in the primary when it comes to asking questions. ASL, language deprivation, and psycholinguistic errors have similarities. Remember that. And they can be mistaken for one another. Again, that's why it's so crucial to have someone like a mental health specialist, but also having a deaf and hard of hearing specialist, having interpreters there to really evaluate this Deaf Plus individual and set up a consultation. Deaf Plus people have the same rights as you do. And they also have the right to refuse treatment and medication. That's their right and their choice. They have the same rights as us, even though we may not agree with their choice. That is their right, and they get to choose. Next slide, please. Okay. All right, so any questions? Anything you'd like to comment on? Ask away.
Yeah, please go on to the next slide. Here we go. Here in California, we have a deaf access program for the region. Of course, NorCal Services of Deaf and Hard of Hearing is under one of those resources, but there are other resources that are available in the different categories here, and you can see how they're color-coded on the map and to be able to easily follow. There's the northern region, all the way down to the southern region, so you can see the different resources that are available. And if you have any more questions as far as how to help or find an interpreter, deaf interpreter is in need, as far as with understanding and comprehending a person who is Deaf Plus, or just needing more explanation related with that, there's plenty of information here related with those resources. So go ahead and take advantage of those, contact them, and you'll be able to get plenty of resources, which has detailed information. Maybe it's referral services. I can connect you to someone. Amanda as well, she can do those as well with referring. So that's there on the list. Also, Amanda is involved with different deaf mental health professionals. So if you need to join in on a meeting to learn about that, you can definitely go through that with Amanda. All righty, we'll go on to the next slide. Here is our slide as far as a wrap up. If you all want to provide feedback, or if you have if you want the phone number or just any questions, go ahead and take a picture, screenshot this here, which has the information of NorCal's contacting information. So go ahead and contact us by email or phone, video phone, but the information is listed here. And we really appreciate all of you all for being involved with this seminar. And if you all have any questions, go ahead and contact NorCal. We can definitely expand on that in a depth way, in an approach of how to best suit those who have accommodations needs related with being deaf and having being Deaf Plus But you can definitely get those assistance and information to be able to have a successful plan related with those individuals. And again, we definitely appreciate you all for coming out and watching this seminar, and you all have a wonderful, wonderful day.